find our interesting case presentation. This is just a simple case. It's a one look, one diagnosis. So let's start. So this is a case of HSH, 12-year-old boy complaining of abdominal pain. Just a quick history. One day prior to consult, patient complained of epigastric pain, which prompted consult in our ER department. SFA was done. So the SFA showed an unobstructed bowel gas pattern, essentially unremarkable. So the patient was sent home. Few hours prior to consult, there's persistence of the symptoms. Now the patient is complaining of radiation towards the right upper to the lower quadrant. They sought consult with their surgeon, and they were considering acute appendicitis. CT whole abdominal CT scan was requested, which they did outside. But according to them, they could not delineate the appendix. So they came back to our institution for contrast enhanced abdominal CT scan. So this is the plain abdominal CT scan of the patient, which we checked before going through with the contrast. So let me just show you this. All right. So again, this is just a simple case. What we saw in this axial, coronal, and sagittal views of the plain abdominal CT scan of the patient, there's a fat attenuating ovoid density with a central hyperdensity and surrounding fat stranding along the hepatic flexure, adjacent to the right inferior hepatic margin. It measures 2.5 by 2.2 centimeters, reflective of epiploic appendagitis. Fat stranding densities are also seen extending inferiorly, more prominent along the anterior wall of the mid to distal ascending colon, which demonstrated mild wall thickening, suggestive colitis, probably reactive. We also checked for the appendix of the patient, which measures 0.6 centimeters at its widest diameter without periappendiceal fat stranding. So the patient was diagnosed with epiploic appendagitis. So what is epiploic appendagitis? It is a rare cause of acute abdominal pain in the pediatric population. The pain is usually non-specific, but according to a study, most of the patients are complaining of sharp or stabbing pain. This is usually seen in the 4th to 5th decade with male predominance, but in pediatric cases, according to one study, they are very rare and do not have sex predilection. This is also more common in the obese people because they have excessive fat tissue and larger epiploic appendages. Sizes ranges from 0.5 to 5 centimeters. And usually in one study, common locations are in the left lower quadrant, which is 76% of the time. These are studies done in adults, but in pediatric cases, no study was found. The next one would be the right lower quadrant, which is 20%, and it's rarely in the right upper quadrant. I saw in one study also that in the sigmoid colon, it is 68% of the time. Next would be the cecum, which is 14% of the time. Next would be the descending colon, 8% of the time, and next would be ascending colon, which is 7%. So to better understand the pathophysiology of epiploic appendagitis, we should define what are epiploic appendages. So these are pedunculated fatty structures that occur in rows on the external aspect of the colon, adjacent to the anterior and posterior tenia coli. Usually, the sizes are 0.5 to 5 centimeter in length, with the largest located near the sigmoid colon. The sigmoid colon and the cecum harbor the largest number of prominent and elongated epiploic appendices. So, for an epiploic appendix is supplied by a small end artery of the colonic vascular branches and is drained by a tortuous vein that passes through its narrow pedicle. So this delicate blood supply, combined with the extreme mobility of the fat-laden and heavy epiploic appendices, are prone to torsion, kinking, or stretching with subsequent venous thrombosis. That's why they cause ischemic and inflammatory changes. Differential diagnosis would be if it's in the right lower quadrant, would be we should look for the appendix because they were considering appendicitis. Diverticulitis if there's saccular outpouchings, mesenteric panniculitis when there's misty mesentery, and also omental infarction. it is really hard to differentiate between the two, epiploic appendagitis and mental infarction, as you can see here. But according to a study, the usual findings for epiploic appendagitis would be fat attenuated mass with hyperdense stream, central dot sign, and fat stranding densities. While in mental infarction is a solitary large, non-enhancing mental mass with heterogeneous attenuation. Although the mental infarction may have the same appearance or resembles the appearance of acute epiploic appendicitis, it lacks the hyperattenuating ring, that's, hyperattenuating ring. In addition, whereas the central focal lesion in acute epiploic appendicitis, it is most often less than 5 centimeters long and is located adjacent to the sigmoid colon, while in mental infarction, they are usually seen in the predominantly on the right side or right lower quadrant. So for our patient, what are the usual findings for epiploic appendagitis? So first, look for the antimesenteric fat attenuated mass with a hyperdense rim with adjacent fat stranding. There could also be a thickening of the colon wall, which is reactive, and the specific central high attenuation dot sign, which is represent the thrombotic vascular structures in the center of epiploic appendages. Just showing you another example of a 10-year-old boy complaining of right lower quadrant pain. In the image shows you a inflammatory fat attenuated mass with hyperdense rim and central dot sign, characteristic of epiploic appendagitis. Another example of a 33-year-old male complaining of sharp pain in the left lower quadrant. This is an ultrasound image of the left lower quadrant showing you a reactive bowel wall thickening with inflammatory changes in the pericolonic fat adjacent, with showing the adjacent oval non-compressible hyperechoic mass without internal vascularity surrounded by a subtle hyperechoic line and at least some lymph nodes. Same patient, contrast enhanced CT scan was done of the abdomen, showing you moderate reactive wall thickening of the descending colon, descending and sigmoid colon, and a non-enhancing adjacent fat density ovoid structure with high density rim and surrounding fat stranding. Another case, 40-year-old male with right upper quadrant pain. MRI was done showing you a rounded lesion with a high signal intensity on T1 and T2 weighted images, situated on the anti-mesenteric border of the fat flexure. On contrast, showing you a rim enhancement on contrast. For treatment, it's basically a self-limiting disease. Intravenous fluid and non-steroidal anti-inflammatory treatment is done. Surgical treatment will only be done if there's recurrence at the same area. On surgery, they do just the laparoscopic approach with a simple ligation and excision of the appendage. Thank you, and here are my references.
Okay, thank you, Dr. Andre Hocson. I just have one question. Because you started your case with a pediatric case and then you gave other cases involving adults. So could you tell us a little about the epidemiology, the incidence?
Um,
How?
yes, Doc.
Yes, yes.
Yes, Doc. Actually, Doc, I was looking for predominantly pediatric cases for the epiploic
Mhm.
appendagitis. It is more common in the adult population. I saw in one
Yes.
8 out of 100,000 cases, I think, of abdominal or abdominal CT scans. But when I tried to look for pediatric cases, they just showed case reports. In one article, they said that the
Mhm.
of in pediatric it was unknown, still unknown right now. I'm not sure if it's updated. So,
Well, there have been articles stating that in pedia, it is a rare lesion, affects only less than 20%. Uh, and then, true, you were right that it's very hard to differentiate with a mental infarction. Maybe we could use the size and the location, as you have stated in your table. Very good
yes, Doc.
table. Mostly, the epiploic appendagitis is found in the left lower quadrant, while the omental infarction is at the right upper to lower quadrant. And in
Yes, po, Doc.
terms of the size, not really reliable, very reliable, but we could start from there. And one thing, there is no central hyperdense dot sign at the omental infarction. Usually, it's just a whole glob.
Yes, Doc.
It's just a whole uh, stranding, ovoid stranding of fat, and that really sets it apart from epiploic appendagitis. But I had an experience in BOB in which they accepted both answers, epiploic appendagitis and a mental infarction, because really there is no clear delineation between the two. So thank you so much, Dr. Andre. Very
Thank you,
good
Doc.
report. Thank you.
Stop.
Our next reporter, please. While waiting for Dr. Thurl in setting up his slides, again, thank you so much, Dr. Andre. I would like to welcome in the virtual room Dr. Laya, Dr. Paner. Good afternoon. Dr. Marte, hello, good afternoon. Our next resident presenter is Thurl Cledera. He is currently a third year resident in St. Luke's Global City. Are you ready, Thurl? For our residents while waiting for Thurl, do you have any questions for Dr. Andre?
Sure.
Ayan. Okay, we can see your slides now, Thurl. Thank you.
Hello, good afternoon, everyone.
Afternoon.
Okay, so I'm here to present my interesting case presentation. So we have a case of NVD, a 15-year-old female. She had a known history of congenital heart disease, currently experiencing difficulty of breathing, tachycardia, and chest heaviness accompanying physical activity. She had no pertinent comorbidities and no prior surgical history. She also didn't have any prior imaging. She came to our institution for a cardiac MRI. So here we see this in this coronal balanced turbo field echo image. Immediately we can see that there's marked cardiomegaly, predominantly in the right side of the heart. So since we don't have any previous images in this patient, you have to analyze the images carefully to check what kind of congenital heart disease this patient has. And first, we determine the viscera atrial situs. We look at the abdominal organs. Here you can see the liver, the stomach, and the spleen in their normal positions. And we can also see the supradiaphragmatic portion of the inferior vena cava, which helps us delineate the anatomic right atrium. So here I included this is a four-chamber view of the heart. The image next to it, I put a diagram so that we can better appreciate the images. So in this patient, the left atrium was small in diameter and was supplied by two superior and two inferior pulmonary veins. So it drains into the left ventricle, and the left ventricle was also normal in this patient with good systolic function. And and it and the aorta arises from it and is left-sided. If we note here, the intraventricular septum, there's bowing towards the left, which is suggestive of a pressure overload in the right side of the heart. Immediately, we notice that the right atrium is enlarged in this patient. To better look at the right atrium, let's look at the valve leaflets in this patient. So, so here in the anterior uh, valve leaflet is the proximal portion. The proximal portion of the leaflet is normal in location, which determines the tricuspid annulus. And here we have the distal portion, which is elongated and apically displaced. And then we also see that the septal leaflet is also displaced apically as well. So here in this oblique image of the right side of the heart, we can appreciate the posterior leaflet. It's also apically displaced, and if we notice, there are muscular stumps that are tethering towards the posterior leaflet, causing it to be tethered and with resultant malcoaptation of the valve leaflets. So here in the cine image, you can see the function of the right atrium as it drains into the right ventricle. So immediately we can see some swirling flow voids or systolic dephasing. You can see in the region of the enlarged right atrium as pointed here, which tells us that there's severe tricuspid insufficiency in this patient. So in this image, we already see a cord-like structure in the apex. It's a moderator band, which tells us that this is the right ventricle. So the right ventricle in this patient was small compared to the right atrium. So in this patient, you can see that the right atrium appears to bulge into the right ventricle. You can call that as an atrialized right ventricle. And we can also see the functional right ventricle or remaining. So in this patient, we took a volume of the atrialized right ventricle, which is 35% of the total volume of the right ventricle, and the systolic function of the right ventricle of this patient was preserved at 77%. So uh, all in all, we saw other findings we saw in this patient. So the normal anatomy was with the tricuspid valve was seen on the right. So it could be a D loop, and the normal drainage of the great vessels and their origins were normal in relation to the chambers of the heart. So there's atrioventricular and ventriculo-arterial concordance in this patient. Other associated findings we saw in this patient is the atrial septal defect and the angiogram. So this sequential angiogram shows us that there's already bidirectional flow in this patient. So usually we'd expect when contrast is given that we'd see it immediately in the right side of the heart. However, you can see in these images that there's already contrast present in the left side of the heart already. So you can tell also there's already right to left shunting in this patient. Yeah. The steer images and the native T1 map in this patient showed no edema or any intrinsic high signal that could tell us there are any scars or previous infarct in this patient. Late gadolinium enhancement was also not present in this patient as well. So all in all, in our findings, you have cytosolitos, you have the D loop, atrioventricular and ventricular arterial concordance in this patient. If you use the old notation by Van Prague, this patient would be classified as SDS. We also have this plastic tricuspid valve leaflets, atrialized right ventricle, uh, tricuspid regurgitation, and ASD and VSD. So these findings are characteristic for Ebstein anomaly. So Ebstein anomaly is relatively uncommon. It's characterized by this plastic tricuspid valve leaflets, and the degree of this of the dysplastic valve leaflets correlates with tricuspid insufficiency. Usually mild forms may be asymptomatic in childhood. However, as they grow into adults, they could present with symptoms of cyanosis, right heart failure, or arrhythmia. And usually, there's an interatrial communication present in 80 to 94% of patients. But aside from this, we can also see atretic aortic valves, pulmonary atresia, hypoplastic pulmonary artery, and other complex congenital heart defects. So usually in embryology, normally the heart in utero under the right ventricle undergoes delamination, which ends up which forms the valve leaflets in this patient. It's important to note that the anterior valve leaflet is develops earlier than the septal and the posterior leaflets. So usually, if the undermining of the myocardium is late, as shown in the lower image here, it leads to dysplasia of the valve leaflets. They become either adherent or apically displaced. So this is the classic image in a radiograph in a pediatric patient. So usually this is associated with the box-shaped heart sign for reference. However, it's important to know that not all patients present with this. Usually, it will depend on the degree of dysplasia and the degree of the right heart dysfunction as well. So usually, patients with less marked valve displacement and tricuspid insufficiency, they can only have mild right heart enlargement. So this is not seen in all cases. Here's just a sample of a gross image of the heart across a cut section. The arrows point to the muscular stumps that are adherent to the posterior leaflet in this cut section. So here's another companion case of another pediatric patient. You can see the white arrow points to the anterior septal leaflet and the black arrow points to the septal leaflet. So in this patient, there is a lesser degree of dysplasia compared to the case that we had earlier. Because in our case, the valvular leaflets were more displaced to the apex. However, here it's more on the mid wall. So another case. This one's an adult, 22-year-old. This is a haste image or a T2 na black blood image. So here you can see on image A, you can see an enlarged right atrium with the atrialized right ventricle (ARV). The arrows point to the anterior leaflet. On an image B, the shorter arrow there points to the adherent septal leaflet in this case. So this patient had a larger atrialized right ventricle. So normally in these patients, they are already diagnosed, uh, say neonate, usually with echocardiography. However, in this usually the role for cardiac MRI in these patients, it offers better right ventricular quantification of the right ventricular volume and also its size. And usually there are limited acoustic windows in when you do echoes in adolescents and adults. So treatment in these patients may depend on the degree of dysplasia. Usually, mild forms do not require any surgery, and and sometimes if the need may arise later in life until right heart dysfunction develops in these cases. So, in summary, Ebstein anomalies are relatively rare congenital cardiac malformations characterized by atrial displacement of the valve leaflets. It's important to note that the box-shaped heart is not present in all cases. The cardiac MRI provides excellent morphologic and functional assessment, and usually management is complex and must be individualized per case. So these are my references. Thank you for listening.
Thank you so much, Dr. Terrell Cledera. A very extensive presentation of a case of Epstein anomaly. So you were able to give the MRI images, especially the most important one, the four-chamber view depicting the atria and the ventricles. So I would just like to ask, uh, in cases, because this is a very rare congenital cardiac anomaly, so can we also can the CT angiogram be also sufficient in the diagnosis of this anomaly? Because you presented an MRI, so as cardiac CTA, would it also suffice in its diagnosis?
Yes, Doc, cardiac CT can also be used, especially ECG gated ECG. However, usually it's comparing it both with cardiac MR. The problem is with the radiation dose because you're taking it at sequential images.
Mhm.
So usually that's a point of contention for for the cardiologists who request these type of studies for pre-surgical evaluation, as with our case that I presented today. But cardiac CT is
Mhm.
also another modality that can diagnose this.
Yes, you're correct. And what makes MRI more superior in the diagnosis of this anomaly is the emphasis on the tricuspid leaflet abnormality. We're able to see the function, not only the morphological abnormality, but the function of the tricuspid valve. There's defective tricuspid valve, and that brought about the atrialization and causing the right atrial enlargement, right chamber enlargement. Uh, may I please respectfully ask for uh, inputs from our guest consultants?
Hi, good afternoon. That's really an excellent presentation of this rare condition. No? So this is not the first time we have encountered Ebstein anomaly at St. Luke's Medical Center because first we are known referral center for congenital heart disease, and second it's established that we have a good cardiac MRI program, particularly for congenital heart disease. So we do see a lot of congenital heart disease, even both pediatric and adulthood who undergo cardiac MRI. Um, Now, CT scan could diagnose, even ultrasound can diagnose Epstein anomaly, but we don't stop with the diagnosis. Sometimes they want to see the extent of abnormality of the leaflets and also the function, as Dr. Andres has said. No, the MRI could be a one-stop shop where you could see the anatomy, the function, and also the dysfunction on the myocardium because you could do perfusion studies in addition to the cardiac and the function study to the anatomy and function. So you could look at perfusion studies also. Uh, One thing about Epstein anomaly is, of course, there is a left to right shunt because of the BSD, right? Or ASD for that matter. But if the pressure on the right heart becomes overwhelming, you will now reverse, the shunt. Now you will have the right to the left, and it could be irreversible. So it's bad. So you could see that on a functional study with MRI. On X-ray, you see a cardiac enlargement and diminished pulmonary vascularity. So this is what I was explaining the other day, that when you see cardiomegaly with diminished pulmonary vascularity, one of them is TOF, and this is one of them, Ebstein anomaly. However, the heart tends to be larger in Ebstein anomaly. Okay, great presentation. I hope we're banking all our cases now because for the Brand Hour, we could do an internal banking of the lectures. But for case presentations, we could actually put them on a drive where we could review them again, or maybe videotape them or record them, because these are cases. As long as they are anonymized and the additional images that were used are referenced, then we could actually store them, record them, and hopefully we could put it on our YouTube channel when it's already up. Thank you.
Mm. Yes, we will do that, Dr. Laya. Thank you so much for your valuable comment. Again, thank you so much, Dr. Thurl. A very good presentation about Epstein anomaly, especially focusing on MRI images. And last but not the least, for this afternoon's interesting case presentation, let me welcome Dr. Riza Jeresano. Again, let me look at the our participants this afternoon. We reached 40 plus participants. Good afternoon again to our consultants, Dr. Brian Reyes. Good afternoon po. To Dr. Dr. Marika Reyes also right here. Dr. Riza, are you ready?
Hi, Doc. Good afternoon po.
Hello, good afternoon.
Good afternoon, everyone. I'm Riza Jeresano, a second-year radiology resident from St. Luke's Global Center. I am here to present an interesting case. This case is fairly simple compared to the case prior, and this is a supplemental case as from our discussion uh, last week during the brand hour. So we have a 15-day-old female who came in with a chief complaint of non-bilous projectile vomiting. Um, Patient was born preterm to a G3P0 mother who was given ampicillin a few hours before the emergency CS due to premature rupture of membranes. Other pertinent feeding history elicited was patient was given formula milk and previously expressed breast milk via cup feeding supplemented with breastfeeding. Upon admission at the ER, abdominal x-ray was initially requested. As we can see here, we can see paucity of gas in the abdomen, paucity of bowel gas. There is also absence of free air, gross organomegaly, or abnormal calcification. There is intact flank stripes. Then this was signed out as overall paucity of bowel gas, which may suggest fluid-filled or collapsed bowel. Close follow-up imaging is suggested. Uh, Further stay at the ER showed persistence of vomiting. So additional examination was done and upper GI series was requested. Uh, for the image on the rightmost, we can see this is the preliminary image wherein there is further paucity of gas involving the visualized abdomen. This one. We can also note the presence of a feeding tube within the gas-filled stomach. However, on the second image, this image, Upon administration of contrast solution, we can note fair opacification of the stomach without mucosal irregularities or abnormal filling defects. This one. However, despite different maneuvers and additional administration of 10 cc of contrast, there was failure of passage of the contrast from the stomach to the duodenum in the small intestine, even after 15 minutes. We could also note the presence of reflux of the contrast into the thoracic esophagus. Impression for this study was opacification of stomach but without passage of contrast into the duodenum. Consideration include gastric outlet obstruction, such as hypertrophic pyloric stenosis in this age group. Correlation with endoscopy and ultrasound may be done if indicated. So based on our clinical history or chief complaint and imaging findings done on the two studies, here are the here are our main differential diagnosis. We have duodenal atresia, pyloric stenosis, pyloric atresia, midgut volvulus. All disease entities usually present during the first few weeks of life, and all of them present with vomiting. However, for the duodenal atresia and midgut volvulus, it could be bilus or non-bilus, depending on its relation to the ampulla of Vater. And then for the pyloric stenosis and pyloric atresia, they present with non-bilus vomiting because the lesion or the abnormality is noted proximal to the ampulla of Vater. For the classic X-ray or upper GI findings of the four disease entities, for the duodenal atresia, we have a double bubble sign wherein there is distension of the stomach and the proximal duodenum. Uh, while for the pyloric stenosis and atresia, we could see distended stomach. And then for midgut volvulus, classic upper GI findings show corkscrew sign with tapering beak. So with these differentials in mind, additional ultrasound was done, and scanning of the right upper quadrant of the abdomen showed fairly demonstrates a fluid-filled stomach with the presence of the pylorus. This hyperechogenicity is what we call the pyloric mucosa, while this hypoechoic structure here is the pyloric muscle. So upon further examination, we can note the presence of the pyloric muscle thickness measuring 5 to 6 millimeters, while the total transverse diameter of the pylorus measures 14 millimeters, and the total length of the pyloric canal measures 17 millimeters. Then for image B, additional scanning showed shows the presence of the distended gastric antrum with presence of the protrusion of the pyloric mucosa into the gastric antrum. These images are highly suggestive of hypertrophic pyloric stenosis. Subsequently, the patient underwent exploratory laparotomy, and intraoperatively, a hypertrophic pylorus was noted. Then, pyloromyotomy was then done. Post-surgically, follow-up imaging were also requested. As we can see here, this is the image A shows the preliminary imaging taken during the upper GI series, and this was done preoperatively. And then for image B, this was taken day 2 post-op, wherein there is again note of the gas distended stomach without significant change from image A. However, there is presence of the feeding tube distal tip. There is also now note of minimal bowel gas pattern in both hemiabdomen. And image C shows day 3 post-op, wherein the feeding tube chip is again at the proximal stomach. The stomach is now less distended and more bowel gas are now seen in both hemiabdomen. So, for a brief discussion about hypertrophic pyloric stenosis, it is the most frequent surgical condition in infants in the first few months of life, and with an incidence of 3 per 1,000 live births per year. And it occurs usually between 2nd to 6 weeks of life. This happens when there is marked hypertrophy of the pylorus muscle, leading to the blockade of the gastric outlet. Usually, the baby or the neonates are well at birth. However, due to the gradual hypertrophy of the pylorus muscle, this causes blockage of the gastric outlet, leading to projectile vomiting. Ultrasound is the preferred modality of choice. The etiology remains unclear for the pathogenesis of the pyloric stenosis. However, several risk factors have been elicited. So for the family history, there has been study that there is a 200-fold increase among identical twins and 20-fold increase among siblings. Also, there is 5 times more predominance in male compared to females, and twice-fold increase in when there is maternal smoking. And in relation to formula feeding, according to the study of Sukat and Hale, there is 5 times increase when neonate is exposed to formula milk because it leads to overfeeding with larger volumes of formula milk, which may irritate the pylorus, leading to the hypertrophy. Also, breast milk may protect against pyloric stenosis since it has high levels of vasoactive intestinal peptide, favoring pyloric relaxation. In addition, breast milk also has low osmolality, providing better gastric emptying time. Lastly, exposure to antibiotics, more particularly oral erythromycins, have been associated with pyloric stenosis, which is considered as a motilin agonist, resulting into contraction of the gastrointestinal smooth muscles, which would further lead into probable hypertrophy of the pylorus. So since the ultrasound is the diagnostic modality of choice, here are the criteria for us to be able to suggest or imply that the cause is pyloric stenosis. The pyloric mucosal thickness muscular thickness is more than 3 millimeters with the canal length of more than 12 millimeters. Additional findings may also include hypertrophy of the mucosa and markedly distended peristalsis. So these criteria are present, are all present in our patient. So after doing the pyloromyotomy, post-surgical imaging may be done. However, the pyloric muscle may remain thickened after successful surgery. So during the first week, the muscle can be the same thickness or even thicker before the surgery. And we have to note that the anterior part of the muscle may normalize first, usually by 3 months, then followed by the posterior part of the muscle. This is in relation to the anterior surgical approach done during the pyloromyotomy. However, when there is continued emesis post-operatively, upper GI may be done. This is done to exclude duodenal leak and to assess incomplete pyloromyotomy or gastroesophageal reflux. Thank you.
Thank you so much, Dr. Riza. Again, another excellent report. Dr. Riza, could you go back to your orange table, the one where you presented the differentials? Okay. Uh, Very good that you did this. You made a table easy for everyone to read and to grasp in just one look. So, just to narrow down the differential diagnosis, your patient started initially as a well baby. Is it
Yes po.
right?
Yes po, Doc. Patient was only admitted at the IMCO due to his preterm status and low birth weight, but
Mhm.
generally baby was well.
And then onset of vomiting
Yes po, Doc. At the 15th, around 12 to 15 days of life.
up to 15 days of life.
Yes po, Doc.
Now, so given this differential diagnosis, you can already cross out few of the differentials just by the mere clinical presentation. So the duodenal atresia and pyloric atresia can be crossed out because this is the pathophysiology here is failure of canalization of the lumen
Opo,
of
Doc.
the small intestines. So at initial time, before feeding, upon birth, the patient would already be presenting with symptoms. So this can already be crossed out, but still, it can still be an acceptable differential diagnosis. So you're left with pyloric stenosis and midgut volvulus. Because these two entities, the baby would start initially well, the baby would start feeding well, in our patient, the baby, as you have stated, started to have projectile vomiting at age 12 days old. So around this time, there have been literatures that the exact etiology for the hypertrophy of the pyloric muscles cannot be ascertained, but the pyloric muscle thickening starts after birth. They do not start to thicken before birth. And the eventual muscle thickening as it gets thicker daily after birth, the degree of muscle hypertrophy will determine the degree of onset of obstruction. In our patient, it started on the 12th day of life. In most literatures, they say after a week, after 2 weeks. But the clincher here is that the baby starts well, the baby starts feeding well, and then it stops because of the intractable vomiting. So, so that's a clue. The baby starts well. For midgut volvulus, this is an emergency case, and as I have mentioned in the Brand Hour, whenever we would do upper GI series for ruling out midgut volvulus, for ruling out volvulus, we need to call a surgeon to come with us, to join us during the procedure, because this is an emergency case. So thank you so much, Dr. Riza. Questions from the audience, comments from our guest consultants. So, if there are none, thank you so much again for our three presenters today, Dr. Andre Hocson, Dr. Cledera, and Dr. Riza Jeresano. They were able to present cases, very good cases involving the epiploic cases of epiploic appendagitis, very rare case of Ebstein anomaly, and lastly, the hypertrophic pyloric stenosis. Again, thank you very much to everyone. Have a good afternoon.